Hello again, ladies and gentlemen. Welcome to our talk on lung cancer. Very, very, very pertinent topic because this is the number one cancer killer. So very, very, very important for you to understand this. It will come up on boards. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. So this is just a preview of what we're going to go into. This is going to be a slightly longer video, but it is extremely high yield, so I don't want to skimp here. I want to cover all the pertinent facts because this can come up on any of your steps. And I will try and point you to what's more important for step one. I'm not going to cover the pathology here, but there are quite a few things that you're going to need to know about this for step one. Obviously, step 2 and 3, we're going to be focused more on the diagnostics here. Treatment, not super important, simply because it's very complicated. And so it's unlikely to come up on your boards. Okay, so just quick overview. As I said, most common cause of cancer death in both males and females. It's not the most common cancer, but it is the most common cancer death. It is the second most common malignancy overall in both males and females. In males, the more common is prostate, and in females, the more common is breast cancer. It usually presents later in life, 60s to 80s, and that's because this is typically caused by prolonged exposure to cigarette smoke, particularly first-hand cigarette smoke. However, second-hand cigarette smoke is known to be a cause of lung cancer as well. We do recommend low-dose CT screening in particular patients who are at risk for lung cancer. So we're talking about people between the ages of 50 and 80 who have had at least 20 pack year exposure to cigarette. So what that means is if you've smoked a pack and a half of cigarettes for the past 15 years, you're going to be above that 20 pack year smoking history. You should know how to calculate pack year smoking history. Now, if they stopped smoking more than 15 years ago, then you don't need to do this. There is a very high association between lung cancer and smoking. There is only one type of lung cancer really that commonly shows up in non-smokers, and we'll go into that. It can also be associated with asbestos exposure. A lot of times we think mesothelioma with asbestos exposure, and most patients who have mesothelioma were exposed to asbestos. However, if you're exposed to asbestos, the most likely cancer that you're going to go on to develop is, in fact, lung cancer. It can also be associated with radon gas exposure, which is an occupational hazard. It does have a poor prognosis because lung cancer tends to present later. So as I mentioned, history, smoking is associated with all forms of lung cancer, and then there's occupational exposures too. Symptoms are variable, but these patients tend to present with cough and weight loss. If you've got a patient who's older and coming in with cough and weight loss, you need to get a chest x-ray. Other things, dyspnea, fatigue, hemoptysis is a big one. Only a minority of patients, but it's very suggestive. Chest wall pain, bony pain, and neurologic symptoms, particularly weakness. This tends to be paraneoplastic, and we'll go into that. Physical exam, signs consistent with shortness of breath. The chest may be dealt a percussion, especially if they have any kind of large mass, or if they've got an exudative effusion. That's going to be important to be aware of. They may have some lymphadenopathy, or they may have signs of chronic hypoxia like clubbing. These are less common. For diagnosis, obviously the best initial test is a chest x-ray. You'll want to compare it to previous chest x-rays if that's available. Some cases are incidental. However, most are going to be associated, again, with smoking. All right. So sometimes you do a chest x-ray for whatever reason. Maybe you're assessing them for a pneumonia, or maybe you want to get a look at their heart. And you look at the lung field, and the radiologist tells you see a nodule. Well, the first thing that you're going to want to do is you're going to want to compare it to any previous chest x-ray they have. But if it's a new nodule, then you want to know, okay, is this benign or is this malignant? Now, you can't tell just on the chest x-ray. You would need to get a biopsy. However, there are certain findings on the chest x-ray that can point us to more likely benign or more likely malignant. So the size, smaller means benign. That tends to go with any tumor. Calcification. So uniform, concentric, or popcorn in appearance, and I'll show you pictures of those, points to benign, whereas non-calcified or non-uniform calcifications tends to be malignant. Margins, again, this is very typical of all cancers. Smooth margins tends to be benign, whereas irregular margins or spiculated margins tend to be malignant. As far as density, dense solid tumors tend to be benign. Non-solid or a ground glass-like appearance on chest x-ray tends to be malignant. And then comparison. This is, again, common sense. If you were to see the same nodule 2 years ago or more, it's probably a benign tumor. However, if it's new, that's more concerning. So these are your calcification patterns. So a diffuse calcification points to a benign tumor. There's also a central and a popcorn calcification. We're going to go into that. Those align with hamartomas and granulomas, which are, of course, benign. And then malignant, either a ground glass-like appearance or an eccentric appearance, that points to a malignancy. This is a benign nodule here. You can see it's fairly small and it's uniform in the calcification pattern. This is more malignant. You can see this circled in red here. You can see how it's a little bit more irregular. The calcification pattern is kind of ground glass-like here, especially if you can compare it here where you've got more of a solid calcification. You also see some kind of hazy margins, so not very distinct margins. This ended up being a malignant nodule. The differential for SPNs, so it could be benign or it could be malignant. That's here and here. It could be a hamartoma or a granuloma. Hamartomas tend to have that popcorn-like appearance on chest x-ray, and certainly on CT it'll be even easier to see that. Granulomas tend to have these bullseye nodules. So you see calcification kind of in the middle. It looks like that, like a bullseye. Tuberculosis, look for the history. Somebody coming from an endemic country, maybe an immigrant, or maybe they're a healthcare worker. They get a positive PPD test. That points to tuberculosis. Fungal infection or Mycobacterium avium complex, look for a patient with HIV with a low CD4 count. Okay, so what do we do if we see a solitary pulmonary nodule? So first, we want to look at the history, the symptoms, and old chest x-rays. Okay, that's going to be important. Now, if we didn't see this nodule on previous chest x-rays, then we need to look at the characteristics, like I told you. So it could be very clearly benign. It could be questionable. Or it could be very clearly malignant. Okay. So that's going to be based on the appearance. Now, if there's things like weight loss and stuff, you need to factor that in as well. So if it's clearly benign, based on appearance, you can follow them up in 6 months. And you're going to follow them up again after that, usually at a year and then 2 years. But you can just follow them up. You don't need to do anything more by way of diagnostics. If it's questionable, you want to get a CT. Now, if the CT says it's likely benign, so likely benign, then you'll just follow them up. If, on the other hand, it's likely malignant, then we're going to work it up as a malignancy. And so what we're going to do at that point then is get a biopsy. Now, the biopsy will tell us for sure. Now, how do we go about biopsy? That depends on where the lesion is. You can do either a flexible bronchoscopy, or you can do fine needle aspiration, which is transthoracic, or you can do VATS. Now, if it comes back benign, you're done. You know for sure it's benign. You can tell just based on the biopsy. On the other hand, if it's malignant, then your next step is going to be to assess for treatment. You want to stage the tumor. Okay. So that's kind of our algorithm here. Upon diagnosis of lung cancer, you want to get routine labs, get a CBC, get a comprehensive metabolic profile here. Then you want to do imaging. So a CT, if you haven't done that already, typically you have. You want to get an MRI of the brain, although we usually just go whole body looking for metastasis, and you can get skeletal radionuclide imaging. All right, so I've got some pictures of some solitary nodules here. This one you can see very central. So this might be a squamous cell cancer. This one's a little bit more peripheral here. So again, I just have a lot of pictures here that you can look at. So this here is relatively small, but it actually did turn out to be a malignant nodule. You can see here that this is much more peripheral. Okay, so what are our types of lung cancer? Well, first of all, we can divide this up into central. I didn't know I could move. Oh my goodness, I'm moving this around. Okay, so we can divide it into central and peripheral, just based on the location. And sometimes it can be hard to see on chest x-ray, but a CT will really help you with that. So of the central tumors, we have small cell lung cancer, and then the rest of them are called non-small cell lung cancers, but they have particular names too. So what do we mean by a small cell lung cancer? Well, first of all, this is strongly correlated to smoking. Okay, it is very rapidly metastasizing. And there are some paraneoplastic syndromes that you tend to see with small cell lung cancer. And those are the Lambert-Eaton myasthenic syndrome, which remember looks a lot like myasthenia gravis. However, the muscle fatigue will improve with repeated stimulation. And then SIADH. All right, so that's pretty much it for small cell lung cancer. If you're taking step one, make sure that you know how this looks on biopsy. Now, the other kind of small cell lung cancer is squamous. And the way I remember this is squamous and small cell are central. Kind of alliteration there, right? So with squamous cell lung cancer, again, strong correlation with smoking. These tend to show cavitation on imaging. And these also cause paraneoplastic syndrome. The paraneoplastic syndrome that you would see here would be hypercalcemia of malignancy. Now, why does this happen? Because these tumors secrete something called parathyroid hormone resembling peptide. And what that does is it basically mimics parathyroid hormone. Now, if you were to get a parathyroid hormone level, well, you're going to see a low parathyroid hormone level. Why? Because what this is secreting is not parathyroid hormone, but it works like this. And so it'll increase your calcium, and then you'll have negative feedback, which will reduce your parathyroid hormone. So you kind of see a paradoxical pattern here. Okay, now for the peripherals, we have adenocarcinoma. And this has a very unique appearance on pathology. If you're taking step one, make sure you know that. Now, adenocarcinoma is going to show up in non-smokers. Now, most people who have adenocarcinoma get it from smoking, but if you are a non-smoker and you get lung cancer, you're most likely to get an adenocarcinoma. This can show up with a pleural effusion. Okay, so that's where we talk about those patients with dullness to percussion. They may have a pleural effusion that'll show up on chest x-ray. These tumors can show up as Pancoast tumors. So what that means is that can lead to a Horner syndrome. Okay, and now the last one is large cell. This by far has the worst prognosis, although all of these have a pretty bad prognosis. And what you'll see here is cavitation. This is the least common. Now, which of these is the most common? Adenocarcinoma is the most common. Now, squamous, adeno, and large cell are also called non-small cell lung cancers. Now, one more thing, you can see it with any of them, but particularly small cell lung cancer, I just want to bring this up. Another feature that you can see here is superior vena cava syndrome. I'm not going to go into that, but basically what happens is that large vein, the superior vena cava, gets blocked, and so you can get symptoms, particularly in the arms and in the face. Okay. So this is just a pie diagram here. You can see adenocarcinoma is number one. It also, a good chunk of them happen in non-smokers compared to small cell carcinoma, which is very rare in non-smokers, as well as squamous and large cell. Large cell being the least common, adeno being the most common. Now, what do we do as far as surgery? Well, not all patients are eligible for surgery. It depends on the stage as well as their pre-existing pulmonary capacities. So the staging is based on the tumor size, the lymph node involvement, and evidence of metastasis. Remember the TNM staging, tumor node and METs. You don't need to know how to stage them, and so for that reason, treatment is unlikely to come up, but it's good to know that if you're dealing with stage 1 and stage 2, these are definitely candidates for surgery, so you may do a surgical resection and then adjuvant chemotherapy afterwards. Stage 3 and 4 tend to not be amenable to surgery. Stage 3A may be amenable. You're not going to get asked about this. Stage 3, it really just depends. However, the later stage 3 and 4, we tend to just do palliative chemo and radiation. This is usually terminal. Now, is the patient eligible for surgery? Even if they have stage 1 or 2, they may not be eligible. It depends on their FEV. So if their FEV is more than 2, they tend to be eligible. If it's less than 1.5, they're not eligible. In between then is controversial. So what you need to get out of this, though, is that if you've got a patient that you think may be able to get surgery, you need to get pulmonary function tests. Other tests, a sputum sample can be performed if the chest x-ray or CT shows a central lesion. It's good for detecting squamous cell lung cancer, but others really not so much. Thoracentesis with cytology can be performed if there's an effusion. And then VATS, which is video-assisted thoracoscopic surgery, can be performed if a fine needle aspiration is unsuccessful. You can also get an FNA of the lymph node. That's particularly if you have spread to the lymph node. Now, this is a hamartoma. This is benign, and what you can see here is this popcorn calcification. I'm going to try and change to red here. So here is your tumor. You can see kind of that calcification in the middle. Looks kind of like a kernel of popcorn. So here's another hamartoma right here. Now, the granuloma tends to have a bullseye-like appearance. So you'll see a little bit of calcification in the middle, but not around the periphery of the tumor. So that's right here. And this one's even more obvious. All right, so let's recap. I got a lot here, but this is the most important stuff that you need to know. Lung cancer is the leading cancer killer of men and women, but it's not the most common cancer in either. Smoking is the number one risk factor. Presenting symptoms: cough, weight loss, dyspnea, fatigue, hemoptysis, chest wall pain, bony pain, and neurologic symptoms, which tends to be a paraneoplastic syndrome like LEMS. The best initial test is a chest x-ray. If you got a patient who's a smoker with a sudden onset of cough and weight loss, you're getting a chest x-ray all the time. Features suggestive of malignancy: large, new, irregular. Most accurate test is a biopsy, transthoracic biopsy, or VATS for peripheral lesions, bronchoscopy for central lesions, and that just has to do with the location. Bronchoscopy is not going to be successful for most peripheral lesions. Paraneoplastic syndromes: with squamous, we see that hypercalcemia of malignancy. With small cell lung cancer, you can see the Lambert-Eaton syndrome or SIADH. Adenocarcinoma is the most common lung cancer in non-smokers and is also the most common overall. Eligibility for surgery depends on pulmonary function tests. If you're going to be working a patient up for surgery, make sure and get that. Treatment depends on the staging. Remember, we use the TNM system. Hamartomas show popcorn calcification. Granulomas show bullseye lesions. Both of those are benign. And then finally, the screening: we get low-dose CT on patients annually if they're between the ages of 50 and 80 and they have a 20-pack year smoking history. However, we do not need to do this if the patient quit smoking more than 15 years ago. All right, that was a lot, but this is all super high yield. So if you didn't understand it, go back and watch it again.